without further ado, I'm going to introduce Vikki first, who has worked in the NHS as a GP for 20 years. And 7 years ago, she joined the Leeds and the West Yorkshire Chronic Fatigue Service in a new role as a GP with a specialist interest in ME CFS. She works in this multidisciplinary team, which is consultant liaison psychiatrists, OTs, physiotherapists, a specialist nurse and dietitian. And that's an adult service which covers a wide geographical area. She also started working as a GP with a specialist interest with the Yorkshire Fatigue Clinic, an independent service which was established by Sue Pemberton, an occupational therapist. And they have several NHS contracts to see people from the age of 13 upwards and covering all severities of the illness, again, across a wide geographical area. Vikki conducts diagnostic assessments in both services, along with providing support to therapy groups and teams through regular MDT meetings, and is actively involved with BACME. She's on the board for several years, and she is our communications officer and does a brilliant job. So I'm going to introduce Pete next. Pete is a clinical specialist physiotherapist in the Bristol Chronic Fatigue Service and also team lead. He works in the North Bristol NHS Trust Pain Management Service as well. And he has clinical roles which include input into pain management programs and co-delivery with lay tutors. Pete has been involved with individual rehab programs and group treatment in the Bristol ME CFS service since 2004. And he also has long-standing involvement with the Physiotherapy Pain Association in the Chartered Society of Physiotherapy and collaborates extensively with the Action for ME charity. He also co-authored a report for them in 2010. He supports undergraduate physiotherapy education about ME CFS and is also involved in the delivery of a master's level fatigue course in the University of the West of England. And we feel very lucky to have recruited him to the board. So welcome, Pete. And over to you, Vikki, and then to Pete.
So in this talk, I want to explore some of the research advancements that have been made in the field of ME CFS to look at how we as clinicians can translate this growing knowledge into our own understanding of the condition, which should allow us to provide more informed therapy programs for people with ME CFS. So I feel strongly that the starting point for supporting anyone who has any kind of health problem is to provide an accessible explanation of what is happening in their body. So I'm going to share some of the ways that I bring this research into my consultations to translate it into something useful for that person that will put them in a better place to understand what's going wrong and what they can do to try and help the situation, which I think is an important foundation for any therapy program. So in order to figure out what's going wrong in ME CFS, it's useful, first of all, to look at what the normal process of homeostasis is in the body. So homeostasis is the body's ability to maintain stability when confronted by different demands. So we need to think, first of all, what we mean by demands. So there are internal everyday demands within our body, things like hunger, thirst, processes of digestion, physical activity, cognitive activity, processing emotions, sleep, reproduction, growth, all of those things constantly going on in our bodies. We can also have additional internal demands, those caused by inflammation, injury, infection and disease. And then we also have external demands that our body has to respond to, things to do with our environment. So things such as the air quality, pollution, pollutants, allergens, temperature change in the environment, and then also the effect of gravity on our bodies. So the way that the body maintains homeostasis is via a very wide number of complex dynamic systems that all have sort of feedback loops in it so they can upregulate and downregulate their activity depending on what the demands are. And all of these systems communicate between each other. So in ME CFS, the research is focused on several of these dynamic systems, the main ones being the immune system, the autonomic nervous system, neuroendocrine systems, particularly the hypothalamic pituitary adrenal axis, and then looking down at a cellular level at metabolic processes within the mitochondria. So what I explain to patients is that the process of dysregulation is very different to a static disease process. So if somebody has a tumour, it's the same in the morning as it is in the afternoon, and the fact that they've eaten a dinner or went for a walk won't alter it. But with dysregulation, the symptom patterns are very dependent and influenced by the demands that are acting on the body at that moment in time, but also potentially what's gone before. And then what I also share with patients is to reflect on the fact that pretty much all of the tests that we do in our sort of standard medical practice are static tests. They freeze time. They just look at what's happening at the body at this moment in time. So if we do a scan, we're just looking at the structure of the body at that moment in time. If we do a blood test, it's just saying, this is how much of that thing you have in your blood at this moment in time. What none of our standard tests do is measure the impact of demand on the body and how our body responds when we put it under different demands. And even those sort of few tests that we do that are more dynamic tests, such as exercise tests or tilt table tests, can be greatly influenced by what's happening at the time. So it might depend on how dehydrated someone is, how hot the room is, how much they've had to eat, or how stressed they're feeling at the time you do it, or what they did the day before. And it can mean that those tests can give quite variable results even within the same person. So what I refer to it as is that dysregulation is more about how the body is being driven. So I sometimes use a car analogy to explain that to a patient, where I'll say it's like having a car and driving with your foot on the accelerator, your foot on the brake, constantly wiggling the steering wheel, constantly changing gear. And you would basically view that car as behaving very chaotically. You'd think there was something really wrong with it. So you take the car to the garage, they park it up, pop the bonnet, look at the structure of the engine, everything's plugged in, everything looks fine. Test the accelerator, working fine. Test the brake, working fine. Test the gears, working fine. Come to the conclusion, car's fine, there's nothing wrong with it. But it's more about how things are being driven that was causing the problem. And the same is true for people with ME/CFS. So in order to look at what goes wrong in ME/CFS, what I'm going to do first of all is just go through each of these systems and first of all look at the normal function and then look at what the research has shown us as to what can change in people with ME/CFS. So the first system we're going to have a look at is the immune system. So this is made up of various structures in the body, such as your lymph nodes, spleen, thymus gland and bone marrow. It's also made up of many different cells in the body, and then also the processes or sort of the programs that are run by those cells. And they use cytokines as the chemical messengers of those various processes. So the main function of our immune system that we all know is to defend our body against attack, particularly from other organisms such as bacteria and viruses. But it also has a huge number of other roles in the body, including things to do with healing, growth, cancer prevention and reproduction. And it's useful to reflect that it's a normal part of our immune system to respond to an increase in physical activity. So that sort of low-grade muscle ache that you get the day after you've done a bit more exercise than you used to is due to low-grade immune activation, which actually helps with tissue repair. That's how we improve the strength in our muscles and also improve our metabolic activity. So the immune system needs to be able to switch on appropriately and switch systems off appropriately. And we've all seen with COVID the devastating effect when the immune system switches on way too loud and you get the cytokine storm, which can cause quite a lot of damage in the body. So it's often also useful to reflect to patients that pretty much all of the symptoms caused by viruses, such as sore throats and tender glands and what have you, are actually things that are generated by our own immune system. So it depends on how much our immune system switches on and when it switches off as to what the symptom severity will be and how long the symptoms will go on for. So in terms of the studies that have been done on people with ME/CFS looking at immune system function, there have been many differences that have been found in people with ME/CFS compared to healthy controls. But the problem is it's not a consistent pattern between different people with ME/CFS, but also potentially across time. So there have been studies that have shown evidence of increases in pro-inflammatory cytokines, but also increases in anti-inflammatory cytokines. So this is often where we struggle with this idea of whether it's an overactive immune system or an underactive immune system. And the reality is it may actually be both. And if I'm talking to a patient, I may use that car analogy again and say it's like driving with your foot on the accelerator and on the brake at the same time, basically over-revving the engine, but not really getting anywhere. So what we see as symptoms may well be sort of individual variation in dysregulation in immune system function, which is basically where you're getting immune activation in response to everyday demands such as physical and cognitive activity. And then the other aspect of this is also to recognise that cytokines can have actions on many other body structures and processes. So we know that pain nerves release cytokines from their synapses, so immune responses can affect our pain responses. And also some cytokines can cross the blood-brain barrier and have direct neurological effects. So this could be one of the mechanisms that can affect mood and also potentially interfere with sensory processing. So the next system we're going to look at is the autonomic nervous system. So this is the neurological system which regulates all of our body physiology. So all of the things that we need to change rapidly in response to what we're doing. So it regulates lots of things to do with circulation, including our heart rate and blood pressure, but also much more complex aspects of circulation regulation, so how much blood goes to different parts of the body. So if you're going to do a bicep curl exercise, then you'd expect there to be a slight increase in blood flow to your bicep muscle. And similarly, if you're going to use your brain to do something such as a crossword or have a conversation, then you need there to be a slight increase in blood flow to the wordy bit of your brain. The autonomic nervous system is also involved in regulating breathing, has lots of things to do with digestion, so saliva production, stomach acid and enzyme production, and also gut motility, so how active the gut is. Also has roles to play in blood sugar regulation, fluid balance in the body, temperature regulation, sweating, and even regulation of the size of your pupils. So when I'm talking to patients, I often refer to it as the body's autopilot. So if you're lying down in bed, the body needs to do something physiologically different to if you're running down the road, and different again if you sat eating your dinner. And the system just operates in the background and constantly adapts our physiology depending on what we're doing. So I'll often talk about the autonomic nervous system being made up of the sympathetic and parasympathetic, talk about the sympathetic being the more dominant when the body is in an active mode, so your fight and flight mode, and the parasympathetic being more to do with digestion, healing, and rest and recovery. So it's important to recognise that these two systems have opposite effects on each organ, but both systems are always active, but there will be one that will be more dominant at a particular time, but the dominant one may actually be different to different parts of the body depending on what the body is doing at that point and what the demands are. And then I'll also explain to patients that this is the system that has to deal with gravity. So depending on whether we're lying down flat in bed or if we stand up, this is a system that has to notice that something has changed and gravity is impacting on our body, and then making the appropriate changes to adapt to that. And the way that I maybe explain this to patients is often by holding up a pen or a pencil and pinching it in the centre and demonstrating it like a seesaw and showing how the system should be nicely balanced, that if we do activity, we expect the sympathetic system to be more dominant, and then we expect it to sort of rebalance itself afterwards. And then dysregulation is like the pivot point has moved. So you then shift your fingers along the length of the pen towards one end and demonstrate that when you apply a demand by wobbling the seesaw a little bit, you get a very disproportionate response in the system, and then also potentially the recovery systems not working properly, and you get this sort of slightly sort of chaotic and unpredictable responses in the physiology in response to everyday demands. So studies that have been done on people with ME/CFS show a definite higher incidence of dysautonomia in this population compared to the background population. And there's been a lot of research in this field in recent years, which has demonstrated lots of issues in the cardiovascular system, in the digestive processes, temperature regulation, and also potentially related to exercise tolerance, because that problem with sort of the fine-tuning of the circulation may mean that not as much sort of oxygen and nutrients are delivered to a muscle when they're doing activity, but also then the buildup of lactic acid may not be cleared as well from the system either. So I always go looking for the symptoms of dysautonomia in a patient when I'm doing a diagnostic assessment. So I'll just quickly run through what the main symptoms of dysautonomia are. So the key one is orthostatic intolerance. So this is people who describe that their fatigue is worse just in response to standing. So I specifically ask them, what happens if you just stand still? So for example, if you stood in a queue in a shop, or if you stood chopping veg in the kitchen or doing washing up, or if you're talking to a teenager, maybe just saying what happens if you just stood still talking to your friends. And people will often use words like drained. I had a lady who described it as her energy just feels like it's dripping through the floor, or people will just sort of say that they start to fidget, have to lean on something, maybe get escalation in pain rather than fatigue, but often have this overwhelming feeling that they just need to go and sit down or maybe even lie down. Another key symptom is also the palpitations. So for some people, there is a very clear postural pattern that they're actually aware of the heart pounding just because they've stood up out of bed. But I think more often, certainly the people I see, it tends to be a bit more random and unpredictable, but certainly just, heart rate setting off for absolutely no reason at all. I always specifically ask about bathing and showering because this can completely wipe people out, and often they're avoiding doing it or having to do it at the end of the day. And people will often explain that they feel extremely exhausted after doing it and may even just have to go and lie down with towels on them before they can even manage to get dressed. Doing tasks with the arms raised can be very challenging for someone with dysautonomia. So things like doing your hair, get things out of cupboards can be disproportionately fatiguing. Brain fog may well be something to do with autonomic dysregulation. I'm going to come on to that in a little bit more detail in a minute. Can cause sleep disruption. So certainly at night time, it could be that if you've got an overactive sympathetic response to your dreams, this might actually keep bringing you into alertness. It may cause disturbed sleep or poor quality sleep, but it can also be associated with hypersomnia as well. So I think that pattern is particularly when people have maybe been doing some physical activity, and when they're moving, they're keeping their circulation more dynamic, but it's the moment that they stop that they have this more dramatic crash. And for some people, it forces them to lie down and they may then actually fall asleep. I'll just point out at this point that my husband does all of my illustrations, and when I said about pupil size, this is what he kind of came up with. So people won't often report a problem with their pupil size, but what they will report is problems with their vision, so maybe just difficulty focusing, but it may also be that this has a role to play in the light sensitivity that some people describe. Temperature regulation can be a key part of it, as can changes in sweating. Shortness of breath can certainly be a symptom of dysautonomia. So people are just randomly feeling breathless or very disproportionate to what they've done. So just going up the stairs and finding that they're puffing and panting at the top. Gut problems can be a significant part of dysautonomia. So if the gut isn't moving correctly, you can get nausea, reflux, vomiting, diarrhea, constipation, all sorts of different things going on with regard to gut movement. And then also potential relationship between fatigue levels and eating. So people will often report that it's a large meal that can cause them to crash, but also some people have identified it tends to be more the carbohydrate-based meals that do that. And this is sort of people who sort of 20 to 30 minutes after they've had a meal have this feeling that they really need to go and lie down. Some people will fall asleep, and it's likely that that's due to a disproportionate fluid shift into the gut in response to having that carbohydrate load that then messes with their circulatory responses and causes that feeling of needing to lie down. So this is one aspect of autonomic research that I find really fascinating, and I very commonly share this with patients, and this is to do with looking at what's happening with cerebral circulation. So these two people are Dutch cardiologists who came to the CMRC conference a few years ago and presented their initial research, which was to try and answer the question as to why the problems with dysautonomia don't always show up on a tilt table test. So although lots of people with ME/CFS have symptoms of orthostatic intolerance, the measurements of pulse and blood pressure on a tilt table don't always reflect their symptom patterns, and they wanted to know why there was this discrepancy. So they started looking at brain blood flow and discovered that a high percentage of people with ME/CFS have evidence of reduced cerebral blood flow, and that happened even in the people who had normal blood pressure and heart rate responses on the tilt table. They also found that there was a link with severity, with the degree of reduction in blood flow, and they also found that there was evidence of reduced blood flow even in the people who weren't reporting overt orthostatic intolerance. And they've published some further research this year looking at this further and linking it with pain responses and also with problems with memory function. And then another aspect of this was presented at the CMRC conference in March this year, which was just looking at 6 people with ME/CFS and looking at their sort of peripheral physiology and then also what's happening in the brain blood flow, just in response to a fairly simple physiological stress of holding your breath. So in people whose autonomic nervous system is functioning normally, when you hold your breath, you get an increase in carbon dioxide, and that results in quite a predictable and consistent change in your brain blood flow due to vasodilation. And when they looked at the 6 people with ME/CFS and asked them to hold their breath and measured what happened, what they found was there was a very unpredictable change in what happened in their brain blood flow in response to breath holding. And it was different to the healthy controls, but it was also different between each of the different people with ME/CFS, which I think just has to send us the message that this is a very complex system. It's potentially unpredictable, and it may be different between different people, but also potentially may behave differently in one person, depending on what's happening in their body or what other demands are going on. So the next system we can have a look at is the hypothalamic pituitary adrenal axis. So HPA axis function can be impacted by many factors, such as the time of day, along with physical and psychological stresses. So the hypothalamus is the part of the brain that links our neurological and endocrine processes. It's involved in regulating metabolic processes. It forms part of our body clock, helps regulate our circadian rhythms. It's involved in appetite, sexual responses, and our emotional responses, and it also connects with the autonomic nervous system. So the hypothalamus releases several different hormones, but in response to stress, it releases corticotropic releasing hormone, or CRH. That CRH then travels to the pituitary gland, which stimulates the pituitary gland to release a different hormone called ACTH, which then travels through the body and has an action on the adrenal glands, which sit just above your kidneys. So the adrenal glands can produce lots of different things, but in response to this ACTH secretion from the pituitary, then the adrenal glands release more cortisol. So cortisol is a steroid-based hormone, often referred to as a stress hormone, because it has an important role in our response to infection and injury. It has a diurnal pattern of production, with a peak first thing in the morning and then dipping in the evening. And this HPA axis has a feedback system, so it can self-regulate when to produce more or less of each of these hormones. So if we look at the studies that have looked at the HPA function in people with ME/CFS, there has been evidence of changes in HPA function, but there's a lot of variability across the studies in terms of their findings. So there are some studies that didn't find any changes at all in HPA function. There are some studies that showed there were slightly increased levels of cortisol, but I would say when there's an abnormality, the general theme has been more towards there being lowered cortisol levels and sort of blunted responses in this feedback system. And it may well be that this variability across the studies may reflect what diagnostic criteria they use or what exclusions. So if you exclude people with depression or exclude people with extremes of BMI, it may be looking at a different cohort of people. So another theme that's tended to come out is that those who do have evidence of HPA dysfunction are more likely to have been ill for a long time. So there's still a lot of questions that we don't know the answer to. So what we don't know is this a primary route into the illness? Is it that people who develop HPA axis dysfunction have a more severe and protracted course of the illness? Or is it that it's a secondary problem that comes about as a result of chronic illness? Is it because of all of the disrupted sleep cycles and the sort of stress on the body of being ill that people then who have more severe ME/CFS go on to develop HPA axis dysfunction as a secondary problem? Or it could even be what's referred to as an epiphenomena, which means it's actually just something that's running alongside that we happen to have observed, but it may not be related directly to the principal symptoms or the illness. So another aspect of the research in this field is finding the association between problems in HPA function and mood. So this is an area where psychological therapies have been studied, and there were studies which showed that biochemical changes in HPA function can happen in response to therapies such as CBT. But the reality is, again, there's a lot of individual variation, and unfortunately we're still quite a long way off being able to subgroup patients accurately to know exactly which therapies would work for which group of people. So next thing we're going to look at is mitochondria. So much has been spoken about mitochondria in this field over the years, and I suspect most clinicians are a little bit fearful of going near the subject. So I thought I'd just give a very quick biology lesson about some mitochondrial function. So mitochondria are present in varying numbers in virtually every cell in the body, often referred to as the powerhouse of the cell, because one of their jobs is to make energy that the cell can then use for various metabolic processes, such as cell growth or getting rid of waste. So those of you who did biology may recall something called the Krebs cycle. And this is what the Krebs cycle looks like to my architect husband. So in its most simple format, that's the process of taking fuel in the form of glucose or fat and then using oxygen to produce ATP, often referred to as the chemical currency of energy. So ATP is what cells use for any process which requires energy. So the process of making ATP using oxygen is referred to as aerobic metabolism, and that's the most efficient way for a mitochondria to make ATP. But they can make it via other pathways which don't require oxygen, and that's then referred to as anaerobic metabolism. But that's a less efficient process, and it also makes waste in the form of lactic acid. And the cell then has to try and get rid of the lactic acid, and it actually needs to use more of the ATP in order to get rid of the lactic acid. So the point where the mitochondria has switched from aerobic metabolism to anaerobic metabolism, and it's making more lactic acid than it can get rid of, is called the anaerobic threshold. So the anaerobic threshold is the thing that athletes and personal trainers become a bit obsessed with, because if you can change the threshold and improve the mitochondria's capacity for aerobic metabolism, then you can improve your fitness and stamina. And that's my husband's visual interpretation of Anne out on her aerobic run and hitting her anaerobic threshold. So we need to look at what happens to mitochondria in people with ME/CFS, and the researchers are fairly confident that ME/CFS is not caused by a primary mitochondrial disease, but there are some people with ME/CFS where there is definitely evidence of mitochondrial dysfunction, specifically related to these aerobic metabolic processes. So in order to understand what's going on with the mitochondria in people with ME/CFS, we can look at the exercise physiology research, as this potentially shows the impact of this cellular metabolic change at a sort of whole person level. So Mark van Ness works with the Workwell group, and they've been doing this exercise research for a number of years. So their original study took people with ME/CFS and healthy controls, put them on an exercise bike to do a very low level of exercise, measured all of their physiology, in particular their oxygen utilization. And what they found when they did this study is there was basically no real difference between the two groups at all. But what they then did was got them back again the next day. And when they did the same test the next day, they got completely different results, with the ME/CFS group showing differences in oxygen consumption and workload. And when they first presented this research, they said that people were questioning whether they calibrated the machines properly, because it was so incredulous that the same group of people doing the same test could get such different results just because they did the test 2 days in a row. But what they explain is that they feel that they're demonstrating the impact of that post-exertional state at a cellular level, where basically there's been a change in the anaerobic threshold in response to the activity that was done on day one. And this sort of demonstrates that this isn't just due to lack of fitness, because fitness would be a fairly static thing. It would be there on day one and day two. This is demonstrating that there's a physiological change in response to the exercise that was done on day one. So it's important to say that when they do these studies, not everybody with a diagnosis of ME/CFS has this pattern shown up on the exercise test. So again, it may be one of those things that varies from day to day, but also it may be that it's just reflecting a specific subgroup under this diagnostic label, but it may be a very important subgroup who need different advice about exercise, particularly about aerobic exercise. So leading on from that, we need to think about what it is that's upsetting the mitochondrial function. So the research initially focused on oxidative stress and nitrosative stress, possibly caused because of this overactivity in the immune system. And that's where patients will have read about this and then try antioxidants to try and improve their mitochondrial function. We also know that viruses have a direct effect on mitochondrial function, and we can see that with things like flu and COVID, where very early on in the illness you get very significant fatigue. So another area that's now been looked at is using this fairly new technology in the field of metabolomics. So Carl Morton is a chap who came and presented at the CMRC conference in March, and this is a direct copy of one of his slides where he's explaining this is our current approach to illness at the moment. Is when somebody's ill, this is our sort of standard batch of blood tests and things that we can do to try and figure out what's going on. And the field of metabolomics is basically looking at this. And within this, there's an awful lot of things that we still don't actually know what they are, but as they sort of progress in this field, they're kind of learning a lot more and finding an awful lot of things that we previously didn't even know existed. So this includes some new forms of organisms, so what they've referred to as L forms. So these are organisms, bacteria or funguses that don't have a cell wall. And what they've found is when they've looked at the ME/CFS population, they have a higher number of L-form organisms. And there's even higher still in the people who've got diagnosis of both ME and fibromyalgia. So the next stage of their research is to try and answer the question as to whether or not it could be how the body is responding to these L forms that might be part of the problem. So could it be the way that the immune system is trying to attack these L forms, and in doing so is inadvertently upsetting the mitochondrial function? So question is, how do we translate all of this knowledge into an understanding of what the symptoms that patients experience and present with this condition? So this is my attempt to attribute symptoms to each of these dysregulated systems. So we'll start with the easy ones. Sore throat and tender glands belong to the immune system. Orthostatic problems belong to the autonomic problems, palpitations due to dysautonomia. Disrupted sleep cycle, we'd think that's the system that regulates our body clock, so we'll put that under HPA. But also important to remember that sleep symptoms, both hypersomnia and disturbed sleep, can also be caused by dysautonomia. Exercise intolerance, we've said that this is reflecting changes in mitochondrial function, but also the autonomic nervous system may have a role to play in terms of that circulation response, providing enough blood flow to provide the nutrients and oxygen and also to clear the lactic acid. Post-exertional malaise, key symptom of this condition. Which system does that belong to? So certainly the exercise researchers feel that they're demonstrating clear post-exertional malaise patterns with their exercise physiology research. But in my mind, the word malaise very much belongs to the immune system. So this is what we mean when people feel ill, like they're dealing with an infection, those flu-like feelings. So we constantly wrestle with the concept of whether post-exertional fatigue is actually a different thing to post-exertional malaise. Temperature regulation, we know the HPA axis is involved in that, but also the autonomic nervous system regulates temperature. Medication sensitivities, I think instinctively people presume that's to do with the immune system responses, but it could also be that it's to do with metabolic processes, and it could even be to do with autonomic problems as well, because that can change gut permeability. So it could be that the way a drug is absorbed is altered, the way a drug is processed is altered, and then it could also be that the immune system may be reacting to things as well. Similar with food intolerances, patients will often attribute to sort of food allergies and start excluding things, but it's important to recognise that an awful lot of gastrointestinal symptoms can actually be caused by dysautonomia. Appetite and weight can also be influenced by the HPA axis function as well. So mood, we know that people get miserable when they get viruses, so it could well be the cytokines getting into the brain that affect mood and behaviour, but we also know that cortisol levels are linked with mood as well. And then also, particularly on the anxiety spectrum, the autonomic dysfunction, so people can have physiological feelings of anxiety without ever having had an anxious thought. Headaches, we know, are very strongly associated with dysautonomia, but also we know you get headache when you're ill with the flu, so there can be contributions from the immune system. Cognitive symptoms, it's mainly the autonomic researchers who've kind of looked at that, but again, it could well be that the immune system has a role to play with sort of brain function as well. Pain, so pain, we know definitely is when you've got flu, you get that generalised achiness all over, and allodynia, where even light touch on the skin is registered as painful. But also pain can be associated with this sort of exercise intolerance and the build-up of lactic acid after exercise, which is also then down to autonomic problems not clearing it. But maybe there's somewhere else that pain belongs that we haven't actually included in this system, which is actually this overlap with the pain research, where we know that you get this phenomenon of central sensitization. So we know there can be overlap with people with chronic pain and ME/CFS symptoms. And then sensory sensitivity could well be the cytokines getting into the brain and altering sensory processing. But again, maybe the sensory sensitivity could go along with this central sensitization problem. So we all know that the process of diagnosing ME/CFS is really complicated. It just seems to get harder the more I learn about it. But it may be that by understanding the symptoms as relating to dysregulation in these various systems can help us understand where the overlap occurs with other conditions. So this is my brainstorm of all the differential diagnoses I regularly wrestle with when I'm doing diagnostic assessments. And I constantly Google each of these and commonly find that people are researching problems with the autonomic nervous system and things like head injury, autism, PTSD, migraine, mitochondrial disease. So in the future, it would be nice if we could find more refined ways of being able to distinguish the subgroups. But currently, this very much relies on us taking detailed histories and knowing how to look for the different patterns of symptoms. So this is my way of trying to make sense of what it is I'm doing with regard to diagnosing ME/CFS. And I imagine it as being like defining a platform at a train station. So it's essentially a destination where somebody has arrived at with a specific pattern of symptoms. But it's likely it's not as simple as just saying that they're on platform 3, as we're almost certainly seeing people on platform 3A, 3B, 3C, 3D. It may even be we're capturing people who are actually on platform 4 and saying that they're on platform 3. But what I think is also really important is try to identify how they got there, because if we can try to understand their route into the illness, it can help the patient to make sense of it. It can help them sort of stop hunting for other reasons for it, and it can get them in a better place to accept that they're going to need to change the way that they live as a result of developing this dysregulation. So if we can identify the route in, it may give us some clues as to the way out. And what I'll often say to patients is just an overarching principle of what we're trying to do when someone has dysregulation is to try and create an environment in which healing and stability can occur again in the body.
Okay, so that's my bit done. So I don't know if any of you have had time to read the NICE guidelines, but I'm not sure I agree with their opening statement that we don't know anything about the pathophysiology of this condition. So I'm going to hand over to Pete now, who's going to talk about how we can translate all of this growing knowledge into effective therapy programs. Over to you, Pete.
I'll share the screen. I'm going to be having a look at a piece of work that a number of you will have been involved in, which is the BACME therapy guide. I thought this would be very timely to look at it again in the light of the growing evidence about dysregulation. So just for those of you who don't know, the guide is really guidance for therapists, not a manual, and it is really covering the whole approach to therapy for ME/CFS, but it doesn't replace any specialist training, for example, that a psychologist, occupational therapist or physiotherapist might need to work in this field. It's very pragmatic. And it was developed in 2014, so it's been around a long time now. It's probably worth it that we look at it again to think about whether any changes might need to be made with it. But it really was a very collective piece of work. I just want to make reference to that really. It was a combination of the BACME membership, Action for Young People with ME, which is now merged with Action for ME, service users. So there's a lot of information come from different sources here, and it's a very much a collective project. Now, just a brief reminder, in case you have forgotten about the 3 circles of Sackett's evidence-based medicine model. We've got clinical expertise, which a lot of which has gone into this model, but also it linked with best evidence. But any clinical care has to involve the patient's preference as well. And I think you could almost replicate this diagram to think about the way in which a document like the BACME therapy guide is built. It's about individual clinical expertise and that collective wisdom that clinicians build up, but also patient experience that fed into it and best evidence. So hopefully we'll be able to draw on some of that again if we do need to revise it in the future. Originally there were 2 parts. There was a symptom management guide and the therapy guide, and they were combined together, but we're splitting them now, partly to make them more accessible. The symptom management guide is due for an update, so hopefully both of them will soon be available in 2 separate parts. So the original purpose was to emphasize a person-centered collaborative approach that can be delivered in an interdisciplinary way. It focused on a therapeutic rehabilitation pathway, but it doesn't cover diagnostic or prognostic issues. And it really is laying the foundations for therapy. It's not a one-size-fits-all. It's not the kind of thing that you can just follow through. It's very much a collaborative process between the therapist and the person with ME CFS, sharing knowledge, agreeing goals, and reflecting on experience. And we should define rehabilitation. There are various definitions. The dictionaries don't come up with great definitions, but I like this one from the World Health Organization. It's a process aimed at enabling people to reach and maintain their optimal physical, sensory, intellectual, psychological, and social functional levels. So it's helping people to get to be as good as they can be with the health condition that they've got. And it involves providing people with the tools they need to attain independence, self-determination. And it's not just about physical recovery, but also with psychological and social recovery and reintegration of the person into the community. And it's important here to remember that recovery in this definition is thinking about a process. So there are many health conditions which are amenable to rehab, and that doesn't mean that the end result is full recovery. So the BACME therapy guide is to some extent a rehabilitation plan, but only to some extent. And this is interesting. It's a plan to regulate bodily systems. So thinking about Vikki's talk, this is a guide that was produced in 2014, already thinking about regulation of bodily systems and how we might begin to desensitize to heightened level of sensory processing. Again, thinking about Vikki's comments about central sensitization and how we could work by doing a small amount of activity at baseline with the aim of building a better balance of rest in all areas of daily life. Having achieved this balance, this sense of better regulation, then the challenge is to build activity gently over time. And the hope was that this involves re-educating the body and increasing tolerance for activities. I suspect clinically that is what we see with people who are able to make progress, but we need to respect the fact that not everyone is able to make progress with this approach. And we don't fully understand why a given person at a given time can take steps forward or others aren't able to. There are four main phases: engaging, regulating, increasing, and sustaining. So they're active verbs describing these phases. I'll go on to talk about those now. It's not as if people move simply from one phase to another. It's a continuous assessment, and that people might, for example, have a relapse and then focus again on the regulation phase. So it's a dynamic process, not a procedure to be followed. So again, it's not a manual. The first aim is about engagement, and this is engaging the patient in a relationship with the therapist that facilitates collaborative working to help achieve the person's goal with the help of the therapist's expertise and knowledge base through self-management and making changes. So we know that engagement's important in all sorts of areas of clinical work. Interestingly, it also influences outcomes in surgery as well, something you'd think would all be about the scalpel. Turns out to also be about a good quality working relationship. Now, I've included a couple of slides here about self-management that aren't in the guide itself, just to add a bit of clarity, really. I know that not everyone likes the term self-management because maybe it sounds a bit like do-it-yourself or something that's left to the patient rather than the process of support or supported self-management, or perhaps the more complex way in which self-management skills can be developed in clinical practice. But this definition, I think, is quite useful. Self-management refers to the individual's ability to manage the symptoms, treatment, physical and psychological consequences, and lifestyle changes inherent in living with a chronic condition. So just thinking about a dysregulation model and thinking about the challenge of self-management with multiple dysregulation, That's quite a lot to think about. There is a lot to self-management, though. It's a big topic. It's a very interesting paper by Schulman, Green et al., who looked at a lot of qualitative research. I'm a big fan of qualitative research. They looked for self-management processes, and the broad main categories were focusing on illness needs, activating resources, and living with a chronic illness. But within that, they identified 75 self-management skills, which is a huge amount of skill. If you think we're not born with this, we're not taught it in school, all of a sudden a health problem happens and we have to kind of learn it from scratch. That's not easy. And I think one of our roles as clinicians is to help people get on board with some of these skills because they're helpful. So included in that list, some of the 75, we have acquiring information, which is partly what Vikki's been talking about, goal setting, problem solving. I've put pacing in red because I just realized it wasn't actually mentioned in the therapy guide back in 2014. And I think it's perhaps confusing for some people that it's not in there, when actually perhaps a third of the guide is about pacing. Other strategies, planning, prioritizing, reducing stress, communicating effectively, making decisions collaboratively, maintaining a positive outlook and hope, maintaining self-worth, seeking support of family and friends, dealing with setbacks, choosing when and to whom to disclose illness. I could keep going. You get the idea. This is a huge range of skills, and I think this is some of what we help people to build up in our clinical work. My way of thinking about this, and I've put my initials there just to say this is my thoughts and not the manual, not the therapy guide, is that there's an overlap between rehabilitation approaches and self-management. I find the Venn diagram approach quite helpful because I strongly suspect that there are rehabilitation efforts which have been made by people with ME/CFS or by clinicians, or a collaborative rehab approach, which has been short on self-management, and that often these rehab efforts have backfired because the patient hasn't understood the principles, the practices, and hasn't owned it and hasn't been able to run the show. And I think there are self-management skills that aren't necessarily about rehabilitation as well, and that's fine, that's important to know. So there are situations where people aren't able to make progress with rehab, but they may be engaged with a wide range of self-management skills, helping to keep a dysregulated system at a more manageable, more balanced way of operating. So I won't dwell on this. The engagement phase involves a holistic assessment. So the history, the symptoms, impact on function, physiological well-being, diet, sleep, relaxation, exercise, everything that might be helpful for the clinician to know, for the patient to have discussed. But also some of this is about regulation of systems. The guide then moves on to the regulation phase. Now this is interesting. This is almost prescient, isn't it, from 2014 to start talking about regulation. But we're looking at the way in which therapy might help to bring about more of a regulation in systems. So supporting physiological homeostasis, looking at sleep, diurnal rhythms, nutrition, looking at the balance of daily life, the patterns of activity and rest, which I'm quite comfortable to say is pacing, quality sleep and rest. And this is about enhancing parasympathetic activation. Vikki was talking about the imbalance between the sympathetic, the parasympathetic. So looking at skills that help with that, relaxation and mindfulness may well help with that as well. So we're looking at a range of skills here, but it's broader than that. I think we could perhaps be adding more in about sleep management as well. There's a lot of knowledge built up in related fields about managing pain-related insomnia, for example. So I think we could be helping people more, and perhaps there could be more in the therapy guide about recognizing the difference between fatigue and sleepiness, looking at sleep habits and routines, using self-management to look at any factors that increase arousal that might be interrupting good quality sleep, learning to facilitate the internal body clock, and looking at self-management of daytime sleepiness. So these are my suggestions if we do expand the therapy guide to look for better regulation. But there's more to regulation. Looking at what somebody believes, their sense of control, self-efficacy. This is really important work. And building in self-compassion with permission to stop or change. We're our own worst critics. We push ourselves beyond what is helpful. And building in self-compassion may well be an important self-regulation skill to help with managing ME CFS. I suspect it is. Communicating with others is important, dealing with physical and social environments, and we often get involved in those areas as well because they're so important. Also looking at some kind of sustainable starting point that may be the basis for increases in the future, looking at goal setting. So that's that key area of pacing, the baseline setting. But also looking at what gets in the way of regulation, what are the barriers, and using a collaborative approach to look at that. And there may be a whole range of factors that make it difficult for people to find stability. Now, this is a very familiar image for us, the boom and bust, the over and under activity cycle. And we're used to drawing out the boom and the bust in a graph shape. What I find really interesting from Vikki's talk, talking about dysregulated systems, if you look into systems theory, you'll quickly come across ideas about delayed feedback and how delayed feedback in systems can set up feedback loops. And I think this is what we see in the clinic is feedback loops. Somebody feels better, they do more, there's a delayed reaction, there's a feedback loop. So this fits completely with a dysregulated system. And this is one of the big areas that we help people with. We help people with activity analysis. You know this stuff, I won't dwell on it. But looking at color coding, re-establishing what is now high demand, different from before, what is good quality rest, trying to help people understand what the patterns might be, and trying to look at those patterns to see if they could be managed differently, perhaps with a better pattern for sleep, for rest, with the aim of establishing some kind of daily regulation that may be helpful as a starting point to build on. And we're used to using planning diaries. There's a range of these as well. But again, looking at different activities, physical activities, cognitive activities, the balance of these things with rest. This is all about regulation. The guide then moves on to the increasing phase. Now, this is clearly an optional phase. It's important that patients know this is optional, that we know this is optional, that we can help people to stabilize, but then patients might want to build up from that. And the starting point is, again, to go back to baselines, to have that conversation about where is somebody at that particular time, what might be a manageable amount of activities, to find out what they're intending to work towards, what it is that they might like to be doing. And that might be social activities, reading, self-care, all sorts of things might be goals for the individual. And it's a collaborative approach using grading, activity analysis, looking at levels of activities. There's lots of ways of working here. Now, this is, again, something that I've added in partly through my own experience of fatigue over the past 3 years. The center circle is me pacing. The red outer circle is me overdoing it, pushing beyond. And I have this feeling that if I get it right, there's a circle in the middle which is pacing up. That's helped me to build up. But I also have a sense that that zone of pacing up in the early days of me having a fatigue condition was quite narrow, and that these days, 3 years on, the band is broader, there's a bit more room to maneuver, it's a bit easier. I suspect with some patients that I've worked with, their pacing up band is so narrow that their experiences, they can either pace or they're overdoing, and actually working in that pacing up zone is very challenging. And I think it's difficult for all sorts of reasons, really. It is possible that working in the pacing up zone may allow systems to re-regulate, but we don't know that for sure at the moment. I think we need more research in this area to find out whether this careful patient work of staying in the pacing up, the nudging up zone actually leads to better harmony in systems, better regulation. One of the ways of finding out whether somebody's there is confidence scaling. I think this isn't in the manual, sorry, in the therapy guide at present. I find it a helpful tool. I think it's used widely. This is a very simple thing to do. So that my crude drawing here is just sketched on a piece of paper. 0 is somebody being completely unconfident about managing a level of activity in a sustainable way. 10 out of 10 is completely confident about managing it. So somebody is pretty low confidence about swimming 10 lengths. I've just used a simple example of swimming. It could be anything, but much more confident about swimming for 4 lengths. And that's really important, I think, because if somebody's going to approach a new activity that they haven't done for some time, if they're able to think about it in advance and tap into this kind of gut feeling of how confident do I feel? First of all, it's an honesty check. It's just saying, am I approaching this right? Am I biting off more than I can chew? But also, if they approach that activity right, there'll be levels of physiological arousal which are different at that point, if they're approaching something that they feel more confident about. So a bit more on increasing, we're looking at reintroduction of activity. We've talked a bit about that, but also doing things differently. A real world analysis of what works in a given context. And this is what we look at in our self-management groups a lot. It's what works. That's what really matters in people's lives. And trying it one way, if it doesn't work, try it another way. See if we can learn from what hasn't worked. And the experiments, pilot studies are really important. So it's a very much a reflective process. I think what's really important as well is just recognizing any achievements as a win. Any small progress is positive. It's movement in the right direction. There's a complex area that's in the guide about making sense of symptoms and experiences during the increasing phase. I don't think this is easy at all. I think this is one of the most challenging areas that somebody might not be getting very helpful guide from their symptoms to say whether they're in that pacing up zone or in the overdoing zone, unless they've tipped into post-exertional malaise, at which point it's pretty obvious. But that pacing up zone, it's difficult to feel reassured by how symptoms are in that particular moment that somebody's on track. And I think this is where somebody having a good grasp of what they can normally manage, what their diary looks like, what their confidence levels like, all of that knowledge feeds into that sense of, I think I'm okay with this, or maybe I'm not, maybe this isn't working and I just need to step back. And it's that flexible way of working, just to say, actually, I think I'm all right, or maybe I just need to ease back. But if it is working well, consolidation's important, and it's a slow process. I think this is one of the big benefits of moving away from a deconditioning model to a dysregulation model, is it helps us understand that progress is slow with systems. Building up fitness is quick and easy, but the work we do is much more gradual. So I won't dwell on the sustaining phase. It's important, but it's not key to the dysregulation element. But I do wonder, really kind of moving forwards, should we be adding anything to the guide? You've had my thoughts about that, but you may well have ideas as well. And we're very open to ideas as well. So do contribute, send in emails. If anyone would like to be part of a bigger group looking at revising, updating the guide, that would be great. Do we need to cross-match against the draft NICE guidelines? I think that's probably a worthwhile exercise at this stage, although my reading of the draft NICE guidelines so far is that the guide stands up well. As a physiotherapist, I wonder what the benefits are of paced movement in regulating systems. And there are things that crop up in my physiotherapy work about balance and coordination and stiffness that are really important for people and can be helped by paced movement, but we have very little evidence about that. I also wonder if we could be developing mechanistic research Now, a lot of research in terms of health outcomes is pragmatic. Does it lead to better function? Does it lead to better coping? Or it's all about outcomes. That's pragmatic research. But I think this opens the door for mechanistic research. And there is a little of that around. Nancy Klimas has done some mechanistic research looking at the HPA axis. And that would be amazing to make some inroads to look at whether there is a re-regulation underway, particularly in that group of people that we do work with where they're clearly making slow but steady progress. It would be amazing to know what's happening with systems for that subgroup. But we also need to recognise that there are people who don't make progress. This is a long haul for a lot of people. But there may be ways of enhancing self-management and minimising dysregulation that might not move them forwards, obviously, in terms of function. But there may be ways of evaluating that about what's important for them. But again, there may be other things for us to be thinking about in terms of a dysregulation model. So that's a really open question. Is there anything else? And that's really open to the floor. Thank you.